Welcome, I'm Rob Story, Professor of Cardiology at the University of Sheffield in the UK. I'm joined here today by Stavros Spiliopoulos, Assistant Professor of Radiology in Patras University Hospital in Greece. Welcome. And Jeff Dalen, Chief Scientific Officer at Acumetrics in the US. So we're going to be covering the area of peripheral artery disease, the treatment options available there, including issues related to antiplatelet therapy. Stavros, perhaps you can tell us a bit about the types of procedures in peripheral intervention that you're performing that may require antiplatelet therapy and some of the characteristics of the patients that you're treating.
Yes, thank you, Professor. So please allow me a small comment on peripheral arterial disease because we are changing the subject now. So PAD constitutes a major contemporary healthcare problem, as it affects nearly 12% of the general population. And it creates a major cost for all healthcare systems, as it is related with quality of life deterioration, limb amputation, and cardiovascular death. So the kind of procedures that need antiplatelet therapy in peripheral arterial disease are all procedures. So all procedures that are performed in order to treat PAD require antiplatelet therapy, whether these procedures are endovascular procedures, meaning mainly angioplasty and stenting, or even open surgical procedures, bypass surgery using a native vein or a prosthetic conduit. Now, as PAD is a multi-level disease, it involves nearly the whole of the peripheral vasculature. So our procedures involve angioplasty and stenting of the aortoiliac axis, mainly in patients that are middle-aged smokers, and angioplasty and stenting of the femoropopliteal axis and the below the knee arteries, mainly in diabetics and patients with chronic renal disease that present with limb-threatening critical limb ischemia. And we must not forget that these patients has been reported that they are affected by vascular disease in various territories. So 65% of these patients will present coronary disease or cerebrovascular disease, carotid artery disease, renal disease. So we need to give antiplatelet therapy to patients that undergo renal artery stenting procedures or carotid artery stenting procedures. And finally, acute limb ischemic disease sometimes is caused by underlying PAD. And therefore, when we endovascularly treat by thrombolysis or thrombectomy acute limb ischemia, we might need to correct the underlying lesion by angioplasty or stenting again. And again, we have to prescribe antiplatelet therapy following these procedures too.
So tell us a bit about what that antiplatelet therapy consists of. So, I mean, aspirin is the standard background, although some evidence from Capri supports clopidegrel monotherapy versus sort of aspirin as a sort of long-term treatment. But presumably in your intervention cases, you're really talking about dual antiplatelet therapy to give you sort of combined effects of aspirin and P2Y12 inhibitor.
Well, data suggests, and they're based, we are talking now about the updated 2011 updated recommendations of the American College of Cardiology Foundation and American Heart Association. And based on these recommendations, all patients with symptomatic PAD should receive at least 75 milligrams to 325 milligrams of aspirin daily in order to reduce the risk of death, of cardiovascular death, stroke, and MI. And they should receive aspirin also prior to any kind of revascularization procedure, either endovascular or open surgical, or prior to major amputation. And this will lead to a 25% odds reduction for cardiovascular events. However, as you mentioned, the subgroup of PAD patients in the Capri trial demonstrated a 24% relative risk reduction when clopidegrel was used compared to aspirin. So again, there is a class 1B recommendation from the joint document that we mentioned previously regarding clopidegrel 75 milligrams daily, again in patients with symptomatic PAD, whether these will undergo a revascularization procedure or major amputation or not. And again, based on the Charisma data that investigated the PAD subgroup, there is a class 2B recommendation regarding dual antiplatelet therapy in patients that will undergo some kind of revascularization procedure, and they are not at high risk of bleeding. Now, there is another document, a very important document for patients with PAD, the Transatlantic Inter-Society Consensus document released in 2007, which states that all patients that will undergo an endovascular procedure for the treatment of PAD should receive antiplatelet therapy per life, forever, if not contraindicated. And what about asymptomatic PAD? As we previously said, there are 60%, 65% of the patients suffer from vascular disease in other vascular territories. So again, there is a recommendation of giving antiplatelet therapy prescribing antiplatelet therapy to patients that have asymptomatic PAD but suffer from cerebrovascular disease or coronary disease. And there is a recommendation for patients with asymptomatic PAD that do not demonstrate any other kind of vascular disease, but the level of evidence there is low, it's C. And our patients, we should highlight the fact that our patients are usually elderly because the prevalence of PAD increases up to 20% after the age of 70. So we are talking about elderly patients with diabetes, with renal dysfunction, with coronary disease, with cerebrovascular disease that in a percentage of 70% will die of vascular causes. Only 20 to 30% of the patients with PAD do not die of vascular causes. So we have to always balance the risk-benefit ratio because we're talking about fragile patients, really.
Now, when we look at that Capri subset and the rationale for recommending clopidogrel over aspirin in patients with peripheral arterial disease, which NICE in the UK have recommended that as the preferred approach. That's fine when you're comparing the populations, but then what we know is that with aspirin you get a very consistent effect, very high levels of COX-1 inhibition with aspirin across the board as long as patients aren't taking interfering drugs and are actually taking their aspirin. Clopidogrel, on the other hand, you've got a range of response, and you've got patients who have no detectable response to the drug at one extreme and a very high level of response to the other. Now, of course, in the trial, when you look at a population, you don't discriminate. And so, but on an individual level, if you say you swap from aspirin monotherapy to clopidogrel monotherapy, it's a bit of a lottery that they're going to respond to the drug. And so you may actually disadvantage occasional patients by switching from one to the other. Or you may get much more antiplatelet effect with clopidogrel and aspirin if there's a high response and a bit more bleeding risk. So do you think we're sort of rational in terms of how we're actually approaching this choice in terms of monotherapy in PAD patients?
Well, as you previously said, Professor, we only have data from subgroups. So we don't have data for dedicated PAD patients, especially following endovascular procedures. And so, yes, it is a bit of a lottery to change if you don't know if your patient is going to respond to the therapy that you are giving to him. And that's the rationale for platelet function testing. And because we know that from current data that aspirin responsiveness is high. I mean, there is a percent of patients that do not respond well to aspirin too. And according to published data, this ranges between 4 and 40%. And there are some problems with these studies there, but we're going to discuss about that later. But in PAD patients, high on clopidogrel platelet reactivity has been detected in 51%. And that's something that we just cannot look away and say that it doesn't happen. And so,
and they're a high-risk population, the PAD patients, in terms of as you say, usually you've got atherosclerotic disease affecting all territories, and often they may have multivessel coronary disease as well, and so they are a high-risk group who potentially may benefit from more intensified treatment. But as yet, we don't have a rationale for sustained dual antiplatelet therapy in those patients, other than sort of inferring from some post-hoc analysis from Charisma.
Well, believe it or not, the only study that investigated dual antiplatelet therapy versus monotherapy for PAD patients in following peripheral endovascular procedures was published last year by Professor Tepe, Vienna. And it demonstrated that the 6 months clinical results were superior in the dual antiplatelet therapy group without any difference in bleeding events. Not major bleeding events, all kinds of events. So that's the only thing we know. And whether we are giving dual antiplatelet therapy or monotherapy for how long, we really don't know. It depends on local practice, on local beliefs, on the complexity of the disease, on various parameters, but not on evidence-based medicine.
So in cardiology, we know that the response to clopidegrel in patients on dual antiplatelet therapy has an independent impact on the risk of stent thrombosis particularly. What's the evidence in PAD interventions in terms of the impact of clopidegrel response on the risk of negative outcomes?
It's very limited, and the only data that have been published are coming from our group in Patras, and were recently published in JACC. And we investigated 100 patients that were scheduled to undergo peripheral endovascular angioplasty and stenting of the femoral popliteal axis. For the primary endpoint of 1-year cumulative event rate, for the composite endpoint of cardiovascular death, limb amputation, and repeat vascularization procedures due to clinical relapse of the symptoms. And we found that we stratified patients according to the PRU values. And these patients were included in 4 quartiles, 25 patient seats. Patients in the first 2 quartiles had very low PRU values, and patients in the 3rd and the 4th quartile had higher PRU values. And after 1-year analysis, we detected a significant difference in event rate, in cumulative event rate, in patients included in quartile 3 and 4, compared to those in quartile 1 and 2. And more specifically, we had only 1 event in the 1st quartile, 3 events in the 2nd quartile, 12 events in the 3rd quartile, and 21 out of 25 patients suffered a relapse, a repeat procedure due to relapse of the disease in the 4th quartile. And when we performed the Cox regression analysis, multivariable analysis, we detected that high on treatment, high on clopidegrel platelet reactivity was the only dependent predictor for reduced event-free survival at 1 year, with an incredible hazard ratio of over 16. So we performed a ROC analysis to detect which was the optimal cutoff value for our patients. And according to ROC analysis, that was found to be the PRU value of 234, with a sensibility of 92%, specificity of 84%. And
so that's very analogous to the sort of early findings.
Yeah, the early findings
PCI
suggest
patients.
a strong, analogous, and so a strong relation between high on clopidegrel platelet activity and repeat vascularization procedures due to relapse of the disease. So it seems that this phenomenon really affects our clinical outcomes.
And do you think there's a relationship between size of the artery and thrombotic risk? You mentioned it was femoral popliteal procedures. Are they higher risk of thrombotic complications compared to iliac procedures, for example?
Yes, because the femoral popliteal axis has several spots that are very difficult for endovascular surgery. I mean, the flexion spots. the knee level and the groin level, where the artery receives a high mechanical burden of various forces. And so this, in combination with barotrauma from angioplasty and stent irritation, creates a mixture that will eventually lead to reocclusion or restenosis. So it's not a very easy vessel to treat. In fact, the popliteal artery is the worst vessel that can happen to interventional radiologists to treat. While the iliac arteries are stable, they are big, and usually just prescribing aspirin, if it works, following an iliac procedure just works fine. It's not the same for the femoral axis, and it's not the same for the runoff, where there are small caliber vessels below the knee vessels, 2 millimeters, 2.5 millimeters in diameter, that probably need better flow, and probably complex procedures of long popliteal lesions require not only monotherapy but dual antiplatelet therapy, and for quite a long, I think.
Do you think those sort of flexion points may lead to some problems in terms of apposition of the stents and creating
certainly
areas of increased
malapposition,
thrombosis
yes,
that really drive platelet-mediated thrombosis and
yes,
and make it more critical what level of P2Y12 inhibition you've got on top of aspirin therapy?
Yeah, I totally agree, absolutely. And we have seen that with using OCT technology. So we have seen the following angioplasty, malapposition, inflection points of stents used in the popliteal artery, thrombus formation, and we have also seen neoatherosclerosis below the knee arteries following drug-eluting stenting that might also influence the restenotic effect. And probably antiplatelet therapy plays a role there, because when you have aggressive neointimal neoatherosclerotic disease following your procedure, you might need something stronger than aspirin for a longer period
so
of time.
many of the lessons that we've learned in cardiology and are continuing to learn, you mentioned neoatherosclerosis,
yep,
you're sort of finding the same with the peripheral vasculature, and which is sort of rational really, because it's the same sort of same process of atherothrombosis, which is
the same vessel
driving
caliber.
these events. And also, what sort of caliber that you're getting down to in terms of vessel diameter?
Down to the pedal artery, which might be 1 millimeter.
Yeah, so...
And even less in the pedal arch.
Right, okay. So maybe even going further than the cardiologist in terms of the diameter of vessels that you're
yeah, we
treating.
usually don't have to touch those arteries, but sometimes you might need to improve them with a 1 millimeter balloon or something like that, 1.5.
And Jeff, in terms of, sort of drug response, do you think there's clear lessons for peripheral arterial interventions that can be taken from cardiology?
Well, I think so, and the fact that there have been consistent data and consistent associations, even though the number of studies is limited, is quite encouraging. And it's all consistent with the reason that the antiplatelet therapies are given, is there's a desire to see the drug effect, to reduce the risk for thrombosis. And in various disciplines now, it's been shown that if you do have evidence of the drug effect, then patients have better outcomes. And so, the whole intent of the treatment has been achieved in those populations. And that, I think, really speaks to the intent of the treatment and the therapy, and the fact that if you look at it on a small scale, it's all about the platelet. There are comorbidities and other conditions and other risk factors that need to be considered, but in terms of antiplatelet therapies, the platelet is the target regardless of the patient and their underlying disease.
Okay. So what about bleeding side of things? How's that as an issue in peripheral vascular interventions?
Well, it's the same as in other specialities. We are afraid of the bleeding complications, of the systemic bleeding complications, meaning we are always afraid that the patient that is on dual antiplatelet therapy or stronger new agents that we are investigating in protocols might experience intracranial hemorrhage or peptic ulcer that bleeds or GI bleeding. That's the same for every patient that receives for any region antiplatelet therapy. Now, as far as our procedure is concerned, we are performing our procedures under antiplatelet therapy. And there are no data relating antiplatelet therapy to increased bleeding risk, procedure-related risk in our procedures, meaning that we usually get bleeding from puncture site-related bleeding, but you cannot do something else. You have to give antiplatelet therapy to your patient and then puncture him and then just compress good and firm, and that's it. Now, there are some concerns in patients that we fail to revascularize and have critical limb ischemia and are under dual antiplatelet therapy and have to undergo surgery for the treatment of CLI or major amputation. But again, it's a one-way ticket. You cannot just not give antiplatelet therapy. It's not indicated.
Mm-hmm. So how common are sort of major bleeding complications in peripheral arterial interventions, and particularly those who go for surgery?
Well, they're not they're rare really. I mean, we get something like 0.5% of retroperitoneal hemorrhage due to high puncture, mainly. And something like 1 to 2% of pseudoaneurysms have been reported, and even less for arteriovenous fistulas following puncture. So it's not really something that we are seeing very commonly in our practice. It's something that happens once in a month or something like that.
And do you often use ultrasound to guide the
always.
femoral puncture? Always using
always.
To reduce the risk of retroperitoneal bleeds?
Yeah. Always. I think it has not been demonstrated, but according to my experience, it's even safer to use the ultrasound guidance and then just press fluoroscopy for a while and see where your needle is. Yeah. And that's it. Yeah. It's very easy to do and costs nothing.
Yeah. So in terms of bleeding, the main issue is what the sort of level of platelet inhibition might be during maintenance therapy after the procedure in patients who may have increased risk factors for bleeding. Presumably renal dysfunction is not uncommon in your patients.
Well, nobody has investigated that.
Mm-hmm. And they tend to be more elderly patients.
With various comorbidities.
Yeah.
And so you don't want to see a PRU value of 9 in an 85-year-old with various comorbidities. So maybe there is a role for platelet function testing there, not only to see if the patient is receiving the wanted effect and the benefit of antiplatelet therapy following your procedure, but also to stratify whether this patient is in high risk for bleeding, because a major bleeding event in a patient over 80 years of age might be fatal. It's not something that could easily just overcome.
Mm-hmm. Jeff, do you think we're going to see more studies in these different organ areas and peripheral areas in the same way that we've seen in cardiology?
I think so, and I think that's an area of some confusion as well as far as how to appropriately treat these patients, and I think that a lot has been borrowed from the cardiology literature. For example, the fact that you're placing a stent in a patient, we know from cardiology they do better if you have dual antiplatelet therapy on board. And so I think a lot of these things are borrowed, and so I think that we will see more research in these areas, in particular because there's higher event rates in some of these other populations, which makes some of those trials a little bit more feasible in terms of sample sizes, and because patient outcomes are getting better and better as stents are evolving and as antiplatelet therapies are evolving in cardiology, and so in some ways there's a lack of equipoise in trials associated with platelet function testing guided therapy but also the event rates are getting lower and lower, and that requires very large patient population. So I think that these areas, as well as in a pre-surgical setting, regarding using the test as an indicator of the presence of the drug and likelihood of bleeding perisurgically, are definite areas of interest.
And so, Stavros, what do you do if you have a patient who's on dual antiplatelet therapy following a procedure or an ischemic event, and they come back with a further thrombotic event or a new sort of critical ischemia? What's your approach there?
Well, what we use now is that we prescribe dual antiplatelet therapy to almost all patients, if it's not contraindicated, that will undergo a complex CLI procedure. And we prescribe that 7 days before, so that the day of the procedure we can test if aspirin or clopidegrel or both are really working. And if they don't, and we're always talking about CLI and limb-threatening ischemia and complex, long, complex lesions. So if they don't, we enroll these patients in our investigational protocols of platelet function test guided personalized antiplatelet therapy. And we are trying to moderate their antiplatelet therapy using the new potent P2Y12 inhibitors such as prasugrel and ticagrelor. And initial results are optimistic. They seem safe. We have 1 year follow-up right now. We're going to publish this data in the early 2014.
Okay. Great. Well, we'll look forward to seeing more data from your studies and others in this area.
I believe that interventional radiologists must begin to realize that it's not only the device that you're using that matters. It's also the pharmacotherapy that you're using that matters. I mean, you have to lower the blood pressure, control diabetes, give statins, lower all the risk factors of your patient. And then what about antiplatelet therapy? Why not? You have to monitor antiplatelet therapy too. You have this potential, and it seems to adversely affect your outcome. So it's only natural and logical to do that. And we're just waiting for further larger trials to prove the effect of the phenomenon that has on our clinical outcomes, and to establish our role for platelet function testing in the ambit of PAD.
Great. Well, I think that's been a great discussion, and good for me as a cardiologist to learn more about state of the art in peripheral arterial disease. So Stavros and Jeff, thanks very much for a great discussion.
Thank you.